All right, so as I said, I'm Heston Lamar. I probably have run into some of you guys and gals in and out of the ED, and I'm sorry if I hadn't had a chance to introduce myself or what have you. A lot of times it's just like y'all's job. We're running around so fast and trying to do so much stuff, we don't have time to stop and say hello, but I'm really happy to be here. I really enjoy working with paramedics, and when I was in New Hanover, as Lisa was saying, I spent 11 years down there, and I always wanted to get involved with EMS. And the guy who'd been the medical director had been there for about 25 years. I was the medical director of the ER, and actually, the day he retired, I quit my job as medical director of the ER and took his position. So I was pretty excited to get into that job, and one of the things I initially found was kind of one of the shortcomings of our system was we did not have a good first pass intubation rate. We were about 78%. And so we worked really hard, and this is one of the lectures I put together for them. I've kind of modified it some because we're going to be kind of covering a lot of things that are covered in this throughout the day by different presenters. But I'll tell you, over the course of about a year and a half, we got up to an average of about 94 to 95% first pass intubation. And that's not because of what I did in this lecture or anything else. What it's because of is practice. And most importantly, what we're going to cover in this first lecture is practicing managing the airway in a BLS fashion. That really is where you're going to set yourself up for success. It's not all the fancy stuff. It's not the innovation. And despite the fact that, you know, that is a definitive airway, quote unquote, there's plenty of other good ways to manage the airway and to prep yourself for a successful innovation by doing great BLS techniques. So anyway, that being said, before I get into this first slide, the reason not to name this lecture is How to Become an Airway Sniper I came up with the title thinking about one of the guys who was in med school at Wake Forest. I went to Wake for med school, and he sat in class every day, and no matter how early I got there, he was in the second row where you are, sitting there, everything, you know, lined up on his desk. I mean, just absolutely perfectly, like printed out like this. And the thing is, all our lectures were on the computer. And I went by and looked, and he had outlined the lectures and had like blank bullet points and stuff ready to go. Guy had high and tight, you know, military haircut, and got to know him over the course of the years. And turns out he was a Marine scout recon guy, and had served straight out of high school, was enlisted, gone back on the GI Bill, become an officer, and now was in med school on the Navy scholarship to become a physician, going to be a neurosurgeon of all things. And this guy, you know, obviously pretty hardcore, had done, you know, lots of tours in, you know, the thick of stuff as I got to know and talk to him, and I, you know, found out that basically the, you know, the motto of the Marine Scout Sniper is one shot, one kill. And hopefully we'll kill our patients, but the whole idea is, you know, one shot, one chew. So anyway, moving on. So practice. Here is a study from Journal of Anesthesiology. 15 physician resident interns. Good bag valve mask ventilation. Median was 25 attempts for 14 of the 14 to 15 to achieve an 80% success rate. And on endotracheal intubation, a median of 29 attempts for 9 of the 15 to achieve an 80% success rate. So the point is that this is not a skill that anyone learns or does very quickly or agilely first go around. It's very easy to get discouraged. I can tell you, when I was a resident and a medical student, the anesthesiologist would not let us touch laryngoscope blade, and would like literally force us sometimes, even on cases where they would typically have intubated the patient, to bag the patient through the entire case. And they would watch you like a hawk, and if you just got the least little bit of loss of seal, they'd be like, all right, your next case is another bag case. Damn it. And you walk out of the OR and your hands are like this, you like you know, it's because you're cramped up, because you're really having to bag them like for, you know, 30, 45 minutes sometimes. And just having that skill makes a big difference. And although it's obviously a little easier to develop that than, you know, by this study than it is to be good at laryngoscopy, it still requires a lot of practice. Another study, 20 medical students. So they get a lecture, airway practice attempts, and then numerous difficult airway simulations. 6 months later, without any repeat instructions, their skills markedly decline. Again, general anesthesia. So it just goes to show you, you can train people, you can show them how, give them hands-on. If you don't get any ongoing practice, it's just hard to stay good. And you know, if in my prior system, if you didn't have basically an innovation during the month, you had to come in with one of the field training officers or the education coordinator and just do, you know, a few hours on the mannequin, just doing some simulations. And it's not because, I mean, this is people from our, you know, newest to our, you know, most seasoned veterans in our service. It just makes a difference when you're, you know, keeping those skills handy. So this is obviously where we don't ever want to go, is can't innovate, can't ventilate. This is your disaster scenario, and this is the reason why, you know, things we're going to talk about today in terms of assessing the airway for this sort of problem, and also making sure you have good basic airway skills is going to be key to avoiding this scenario that no one ever wants to be in. So, how to become an airway sniper? First, check your own pulse, okay? That's where most of us get all fired up, whether we're doing trauma or doing somebody that's, you know, a COPD exacerbation, whatever. Our adrenaline gets cranked up. You know, we start getting all jittery and shaky and running around like, you know, Chinese fire drill. And it just happens. I mean, you know, and it's hard to develop that calmness. Certainly experience helps, and being in enough of those situations. You know, I can tell you, at least when I first got into this, you know, this kind of situations when I was younger, I mean, I was probably shaking more than anybody in the room. And, you know, it's not that when you get old and you've done it a bunch that you just become, hopefully not too cynical and crusty about it, but hopefully you just get a little bit more calm. But the reality of the situation is hopefully when you get into these situations, a lot of times you know you're going there. You know, you've got a call about something really bad. And you got all this time you're driving down the road, and it's always told my paramedics is talk to each other. You know, what's your plan on the way? You got all this extra time, all this, you know, what are we going to do? You know, who's going to be handling the drugs? Who's going to be handling the airway? You know, what equipment are we taking in? What can we leave in the truck? Yada, yada, yada. You know, come up with a plan ahead of time, your A, B, and C plan, and kind of calm yourself down, take a deep breath, kind of visualize what's getting ready to happen. Because if you kind of have a vision and a plan in your head ahead of time, it isn't quite as stressful once you get there to the real thing. So let's talk about some ways of just kind of looking at an airway. All right, so first up here, anybody can guess what Malampati class that would be? 1? 0. Wouldn't that be nice? I found that online. I thought that was pretty good. Obviously, that's not real. That's somebody's been having fun with Photoshop. But if they were all like that, it would be a hell of a lot easier. But so everybody's heard of the lemon rule, and I kind of got the lemon in here. Everybody's heard of lemon. If you haven't, I'm bad with phonics, so I'm the kind of guy I get a lemon. I'm just going, hell, hell. And I'm going to tell you how I do it differently, which is at the bottom. But I also think lemon should be Leon. I think Malampati should not be in there. Dr. Malampati needs to stay in the operating room. I know a lot of your EMS charts and stuff, you got this drop-down box that you have to choose Malampati. Malampati is something you do preoperatively for an awake patient. They have to be able to sit up and go, that's a Malampati score. Opening the mouth of somebody who's, you know, drunk and has blood and beer flowing out of their mouth while they're in cardiac arrest and give them a Malampati score is, I mean, you might as well just like count the number of nose hairs they have. I mean, it's ridiculous. But anyway, don't get, Lisa will get mad, and as with any system, you don't do your check box, but just realize it's pretty worthless. But do your check box so you're in compliance, but it's still a worthless tool. So you're looking, you're evaluating, you're looking for any obstructions, and you're looking at the neck. The key part of this for actually predicting a difficult airway is number 2, the 3-3-2 rule. 3 fingers or 2 fingers. The most important part is the number 2 part, which is thyroid to highway distance, which is basically from the bottom here to the top of your thyroid gland. You should be able to put 2 fingers between the top of your Adam's apple. These are doing guys, obviously, to the bottom of your submandibular space. If it's really long, like mine, you probably have a deep airway. Okay? If it's really short, the airway is probably going to be high and anterior. those are the ones that are going to give you the messed up views, because you're just going through 3 blade, and somebody's got a really deep airway, and you're not going to get a hold of that glottis or put your tip your blade into the molecula, so your glottis isn't going to come up, you aren't going to see anything. That's what, when I had my back surgery recently, that's what the anesthesiologist found out, sadly, was that he had to change blades because my airway was so deep. And same thing, if, like I said, you want to get one finger up here, that means the airway's high in the anterior, and typically something like a Miller blade can prove more challenging, and you're going to wish maybe you had a glide scope, which, because those things can be really challenging to see, but you with some good positioning and that sort of thing, which we'll get into a little bit, usually you can avoid that complication. The other 3s are, don't ever do the first 3, is can you get 3 fingers in the mouth? Okay, most of your patients, and most of my patients, do not want to be sticking fingers in the mouth. You just kind of eyeball it. Yeah, it's all right. But you know, you can kind of, if you can't get their mouth open, it's hard to get a good view. And then the other 3 are under the chin, the submandibular space. If you do not have room, you got somebody who's all retrognaathic, where their chin about touches their neck, you know, there's nowhere to put the tongue when you're sweeping the blade. So you just got a good potential problem that the tongue is going to be in your way when you're trying to get a view. So repeating, you'll be able to get their mouth open wide, you want a place to put the tongue, and you also want to figure out, you know, how deep or high their airway is, or high anterior, to kind of decide what blade you want to use. Last is what is very cleverly called the Lamar rule by me, is would you want to go out on a date with this person? If you would not really want to go out on a date with this person, you probably don't want to be intubating them either. If they don't like they'd be a good person to kiss, you probably don't want to intubate them. And what I mean is by this. Someone has got a bunch of nasty facial hair, their chin's all jacked up against their neck or sticks out to here, they got messed up teeth, big giant fat tongue, like angioedema or what have you. You know, you don't want to kiss them, you probably don't want to intubate them. You're asking for trouble. And that pretty much covers all the rules and all the demands. So think about that and hope your bag valve mask skills are good. Moving on. No teeth, fat belly, hairy face, thick neck, snores. I don't know about y'all, but that sounds like pretty much sums it up. You know, when somebody's got no teeth, a fat belly, hairy face, thick neck, and snores.
Well, you know,
I got all my teeth though.
Why a fat belly?
Yeah, that's what I want to know.
why is everybody looking at me? Hey, Floyd.
All right. Well, if anybody here got a previous career as nurse or paramedic working in the hospital or spending time in the ICUs at all? No? Okay, well, you'll see people sometimes have these exploratory laparotomies, especially the real big folks, and what they'll do is basically develop an abdominal compartment syndrome. You can see the same thing with bad renal failure patients, people who have liver failure, where they have these big distended bellies. And a lot of times when they do the exploratory laparotomy, especially in trauma patients, they can't close them back because they're